Oh, okay, yeah, that's right. I'd like to call the meeting to order. And, do we need to do a roll call, or are you just gonna check names off?
I have everybody listed and you have four.
Move to approve the agenda.
Did you have any, public participation? No public participation? Okay, great. So is this the time now that I should bring up the values?
Sure.
All right. So, discovered yesterday that at the January meeting, we did not have a quorum. So, we need to, repeat all the action items at a future meeting and then bring those items before the board again.
Almost done. And you are
Plans.
the plans. Yeah, that was all.
Yes, specifically, yes, for the plans, yes.
Just for future reference, no quorum, you cannot actually have a meeting.
So
Don't have to approve the minutes.
that's what I was getting ready to say. We don't need to approve the minutes. So,
Don't we need to approve the minutes of the previous meeting, huh?
Well, this is,
January meeting.
the minutes are there. The meeting was not official because you did not have a quorum. I guess it's up to you if you want to approve those minutes or not.
Yeah, Shirley. I have no problems approving them because it didn't happen. It's just that we can't use the plan, I mean, you can't approve the plans, obviously, because they're in there.
Right,
I'm referring to the January.
right. That's when those plans were presented and approved.
That's in the January meeting.
Yeah.
So I'll defer to you if you think we should approve the minutes. I mean, I should wonder that.
And, well,
Since nothing happened, why don't we just skip it? We gotta redo it all anyway, right?
That's kind of how I feel.
Yeah.
And they're here if you ever want to refer to them for notes or whatever. So, okay.
Okay. So, I guess we move on to old business.
All right, so I have the compliance metrics, just for review. This is just some of our, basic metrics that we are responsible for covering. So it lists our elements of performance that we look at, our exclusion screenings, our code of conduct, basic education that we complete through the year. And if you scroll down, Anita. Just some issues that come through. Last year, we did not have, actually, I take that back. We did have a hotline call in December. I'll update that. We had one hotline call. Issues through compliance through the end of the year. Days to respond, days to review. Basic issues that are coming through. Mostly we have HIPAA concerns coming through, billing and HR related concerns. Mostly the HR concerns are related to, personnel issues, relationships between employees and directors that are being reported through. Tammy was out of town, so I did not get her final quarters in our denied claims or our final information. I will update that at our next meeting for our repayments, overpayment. Excuse me, go down a little further, Anita. And our total claims for internal monitoring, and our government audits. I don't believe we had any, but I'll double check with Tammy and update that at the next meeting. So any question on any of that data for tracking? No major surprises. I will say, I believe reporting is going up for our employees, which I think is a good thing, especially on notifications of potential internal, like HIPAA notifications, and that I think that came with our response of our code of conduct training that we did last year. So I do appreciate employees reporting that.
So this is our new grievance dashboard. That we've been working on.
Smaller, bigger.
No bigger, that's stuff I.
Bigger, I'm so blind. I'm sorry. I think you just have to scroll down to pick up the bottom half.
That's bigger.
Oh, that's much better, thank you.
So if you, yeah, roll up a little and all the grievances open by month, so. From January to date, we've had a total of
I'm
6.
not sure how you want me to show this. We'd set to you.
So move it towards you. Towards you, there you go. So these are by the month. The month of February is me testing. We're still trying to work the bugs out. And up above, it tells you which departments had a grievance. So in January, we had OR and PFS. February was my test. And to date, in March, I've received 3 OB and 1 for DI.
This patient or staff?
These are patient complaints.
These are
These are
grievances.
grievances that come in through the risk email.
It's just the word that you're using, the grievance of word. Yeah.
Yeah.
So a grievance is after a patient has discharged from the hospital and they come back to us with concerns. So a complaint would be a patient that is still in our service, and then we can hopefully resolve it. So a grievance is after care, then it's considered a grievance. Thank you.
So again, we're still working on this. Does anybody have any questions?
So there are 4 separate graphs on here. So there's no correlation specifically between the departments, the one in the upper right and the dates. So it looks like, what is it? Emergency department gets the most, but do we have any way to tell how it's spread out throughout the year? It's throughout the months. We're not there yet, or?
I'm working on the reports. I apologize. So this is, everything we had on a spreadsheet, I plugged in here.
Perfect.
So, yeah, and the numbers that I just reported were from January 26th to March. This is a representation of everything that's been in there. So I will get the dates lined down for you, so you can tell.
I was just curious how they all, how they
Yeah.
correlated. It's not it's not a negative comment, it's just a comment.
It's a work in
As
process.
if I was missing something.
No, you're not.
Yeah, through the chair, we have a system that we use for all of our policies, and we were just adding in our compliance tracker and our risk tracker. So the first part of it that you're seeing is how we're tracking our grievances through it. So we're trying to keep our historical data in there along with what we're going to be putting in. So that way we can try to track trends and seasonal data, because we're trying to see, is there more events that are happening in the emergency department? So when we go into, this is just a screenshot, like Beth will be able to click on the emergency department and she can see all the data behind the scenes of which patients it happened, what the dates happened, and really dive into it. So like on the other side where it says patient rights, clinical judgment, she can also dive into to say, you know, those 6 clinical judgments, did they happen all in one department or were they spread out? So any of the columns we're able to click in on in the system and really dive out more and really get into the weeds on it. So this is more of really an overview of what's happening and where the big picture is 30,000 feet is. Right now, what we really are looking at and trending in our big issues that we see is lacking communication and customer service is when we talk to patients afterwards. If we do better jobs at communication and customer service, that seems to be the trend. You know, patients weren't aware of something or they felt they weren't being heard. And I think all of us can kind of attest to that. You know, you want to be heard and you want to understand your healthcare. And sometimes we get too busy in healthcare and we can't slow down enough to explain things to patients in a way that they can understand it. And I think that's when we put all of our data in, it kind of shows that was really glaring for us to work on. So more coming with this system. The other, and I'll just take a second here because I know we don't have a lot on our agenda. We're also putting in our compliance work plan and our risk work plan. So in May, hopefully we'll have more data pulling out and having a heat map on that. Our reports are a little more challenging pulling out, and it's hard to pull snapshots of the system for the packet versus pulling the software up to show you guys how it looks. So that's the challenge of doing a board package versus a demo of the software system. So, and I know Anita is looking at me like, no, you can't do a demo of the software system. I need it for a packet.
Because the public has. to-
Yes. Yes. So that's the challenge of putting everything in software, trying to do. So I'm going to work with Anita to see how we can show more of what the system is capable of, what we're doing.
Scroll down. So we have a total of 56 grievances since we started entering them in. 3 are open and 53 of them have been addressed.
Any questions on that?
So this will be an action item for the board the next.
Yes, Madam Chair.
I'm Claude Reynolds. I'm not Aaron. This is Aaron. Aaron's the interim director of Heartland Home Health and Hospice. And I've been working with Home Health and Hospice with the data collection and trying to pull information from Matrix Care, which is the EMR that we use on electronic medical record. So it's a work in progress, trying to validate the data and make sure that we're getting clean data out of the system, and making sure we're putting clean data into the system. It's a big, has been a challenge, to make sure we know how to use it, what's in it, what's coming out of it. So we do have we do have a requirement for a quality assessment and performance improvement plan throughout the year. And one thing I want to ask for indulgence is that we look that we got put quality assurance and performance improvement should be quality assessment. And if you would approve those changes, I would appreciate it. And I'm going to fire my secretary. So we did have a quality plan, which is quality assessment performance improvement plan for previous years, but this is new. This is the new plan for 2026. It's based off of the information that we garnered from the 2025 analysis of the data that pulled out of it. And some of the things that we did see that we needed to have performance improvement plans on are highlighted in the plan as well. Yeah, you can scroll. I put just a kind of a summary of the executive summary of the plan and what our metrics will be for the 2026. So the hospice visits in the last days of life would be RH. 56%, the state was 58%, the national is 49.2%. So we're just below the state and well above the national average for those. What we're required to do is have visits to hospice patients in the last 3 days of their life. So we need to have an RN visit or a social worker visit. So we make sure that we're monitoring closely and being able to visit those folks that went at the end of life. So we were a little bit low. We'd like for it to be 100%, of course, but sometimes we just can't predict when someone's going to expire. Well, we have improved over the last several months. Still waiting for some of the data to come in, but I can tell you just by the office talk that we are getting in to see those patients very quickly and expeditiously. You'll notice the HIS comprehensive assessment is 16%. That's one of the things that we had to validate. We found that some of the data that we were entering into, it was the race and ethnicity, which is counts on the assessment tool, wasn't pulling over into the administrator side, so we weren't seeing that data that information on the data. So we didn't do a good job recognizing that soon enough. So now that data's out there, and that's where we stood. We've corrected that, so we're improving. We're going to monitor it, make sure that we are doing those assessments as is required, and getting to our goal. We want that at 100% too. Anyways, I've set it at about 95%. Pain effectively managed, we did well. Still the goal is 100%. constipation effectively managed. When you hospice patient, you are on opioids, so you could have constipation, and we want to make sure that comfort level, and we're addressing those needs as we go along. Hospice hospital admissions are lower than the state national benchmarks. ED utilization while admission is lower than state national benchmarks. Functional improvements is one of the things that we're going to monitor and educate the staff on where we need to be and where what they need to do as far as their assessments and making sure their goals are realistic. Timely start of care is another one that we were below the benchmark. One of the things we found out when we drilled down is that we weren't accounting for patients that were requesting a delay in the start of care. We'll try to get in to see them and they say, well, can you come next week? So we're adjusting that as far as our process is concerned and getting orders to match what the patient needs are. We're of course going to monitor that as we go and monthly. Okay. Staff, go ahead. Sure.
On the spring before that, you were just talking about,
Start of care.
oh, I'm sorry, two before that.
Oh.
The benchmarks. So for me, I think that it's better to be lower than the state and national benchmarks on the ED utilization and
Yeah.
hospital admissions, but functional improvement it is just the opposite, correct?
Correct.
Okay, I just wanted to clarify.
Sorry. Yeah, I should
That is-
arrows. And,
And I'll just say that it's a data collection tool that is generating this information. And basically there's something called OASIS. And it's a standardized government assessment. And it's not about delivering high quality care. It's about how are we answering the question when it comes to, is the patient able to do this? The patient says, sure, I am. And then another clinician goes in and they say, well, actually, I really can't do that. But what did we initially assess? And so when the patient is discharged, the question is from the initial to the discharge, did it show an improvement? And it really comes down to understanding how to answer the question. And so that's part of the focused education. We're going to be providing manuals for every clinician. They'll be able to, it can be like a 15-page OASIS assessment. And there's a new update coming in April 1st, some additional questions. But it's how to understand what they're asking, because two people could have two different opinions on what the answer is.
So again, the information you put in is what we get out, and we'll make sure that what's going in is correct and measurable, and that we get good data out of it. So we can give it to you all.
Yes.
The workforce stability, we had staff turnover rate of 90% last year because a lot of folks left the facility, left the agency through internal transfers. They left hospice and our home health and went to behavioral health. So some of them transferred or relocated out of the area. We were fortunate enough to keep Heather Richter on at a distance. And so she's actually on here today online. That's 7, almost 8 o'clock there where she is. So we're trying to get that stabilized so we have better, have more consistency and training and getting that information that we need into matrix care we're targeting, trying to mitigate the the staff leaving hospice and home care to by giving them education. And Aaron's doing a good job of that. Sure.
What were the raw numbers in terms of staff and raw numbers in terms of the patients? You know, when you say we're, 50%, what's the denominator in terms of the 2025?
As far as the
Total patient load,
patient load,
total workforce load.
yeah, we're probably 4 to 5 patients per staff member. Is that what you're asking?
Actually, the total number in terms of the yearly total.
Like right now, we have about 13 employees,
Yeah,
not all full-time, so
Yeah.
that's just total employees.
Then in 2025, we saw roughly 100 patients.
we got 20, or the average length stays it's around 25, 30. I think that's both home health and hospice. So we run around 4 to 5 hospice patients. We'd like to see that higher, but we're working on that. 25, we'd like to see more home health patients to be able to keep folks busy. And so one of the main drivers too is that they take call. You do 24-hour call for home health and hospice. Mostly it's hospice calls after hours. So, and when you don't have, lately we've only had 3 people, 3 RNs to cover that call. So they're taking 16, 70 days to call a month or more. So we've got 2 people that are interim. They just came on this week. Hopefully it'll take off some of that burden of call for the regular staff members. So it's one of these, this is just kind of what we're doing, just a little bit of benchmark. We're going to actively monitor it. So we're going to pull the data and make sure that we're continuing below the benchmark. Below goal, we'll do a targeted process improvement plan and address those things that we find in the data. Improving trend, we'll continue to monitor that to make sure we sustain that improvement. At or near goal, we're going to just continue to monitor those.
Regarding the question through the chair, roughly about 100 home health patients and 55 hospice patients for 2025.
That's good. Thanks, Heather.
And I'm sorry, I don't know how to turn the sound off on this.
So next page is what we're planning on monitoring, and this is just a roadmap of what we want to do and what we found in 2025 through the 2025 data. The HIS comprehensive assessment has turned into HOPE, the hospice outcomes and patient evaluation. So we're going to want to try to standardize the intake, the flow of patients coming in, and coaching for documentation, making sure that we're entering information accurately. And again, that hope has changed in October of 2025 as far as the documentation and the evaluation is concerned.
And to provide a comparison, HOPE is Medicare's attempt to make it like home health as far as data collection. They want to start mining data. And so now there's some basic questions that we're required to ask patients. And it really is, did you complete a pain assessment? Did you ask about spiritual beliefs? And it could be very well documented in there, but if you don't click the button that says yes, it'll give you a negative. And we have an opportunity to go back in and correct it at review. And that's what I found is, just like the timely start of care, it was updating, the time point. That it was really patients requested a delay. It wasn't that we were delaying them, but you have to update it in the system, and get that physician order, to inform them.
So the next one is the visits in the last days of life. We definitely want to do that as far as, just not just for data collection, but we want to make sure that the patients are receiving those visits to be able to have, what am I trying to say?
Comfortable death.
Comfortable, end of life.
And it's the goal of a nurse or a social worker for 2 of the last 3 days. And so sometimes you could have seen them all week, Monday through Friday, and the family says, you know what, I'm gonna be fine through the weekend. And then Monday they pass away. So you didn't get Saturday, Sunday, or Monday. And so you would not measure, you wouldn't qualify for meeting that need. It's always patient need. So we're not gonna make visits if they say we don't need it. But Medicare really would like to see agencies in general do a much better job at this.
As far as timely start of care, I mentioned that was one of the areas that we did improve on. So we're going to continue to monitor that and put in processes that we can make sure that we are starting care. Workforce stability, we talked about that, targeted recruitment, hopefully a pipeline to Juneau, Alaska, people that want to come up here. Internal mobility and planning to reduce service disruption. If we don't have the staff, we can't see the patients and we can't provide quality care. So the timely start of care again is just a repeat. Quality home based hospital admissions. We'll watch that to make sure that we're continuing to stay above the benchmark. The functional improvement, doing education and making sure that we're being reasonable bills in the patient. The hospice specific monitoring, the HOPE assessment completion, and visits last days of life, falls without major injury, pain, constipation, and utilization and constipation management. The streets of the program, we had the low hospital admissions, ED utilization, and home health, strong symptom management and hospice at 98%. And so the priority gaps again is that hospice, HIS, the comprehensive assessments that we're implemented and now educating on the HOPE and making sure that we're providing that education and completing that completely. That's just the appendix to what CMS is going to request of us. The next is just our plan. And we need approval for that. It's kind of a repeat, just tells you how that we're going to do it and what we're going to do and how often we're going to present to people regarding our quality metrics.
To the chair. The one thing that we are building that you will see in the quarterly reports attached to the board quality is you have the hospital, you'll have the wildflower board metrics, and now you'll have a hospice home health metrics that are built out on all of their metrics. So either Erin or as long as Claude's here, you will have it be a reporting off of that every quarter now.
And I can share through the chair that these are daily things we're monitoring. And we're going to internally make sure weekly, monthly, we're going in the right direction. And many of these things are well in process of improvement.
And I will say, following the plan is just that. This is a roadmap. If we find something during the data collection and monitoring that needs to be reprioritized, and we'll start monitoring that and report out to you. It's just a plan. It's what we plan to do, but if something comes up that's more important, then we'll refocus our efforts on this.
Is it okay if I make the motion?
Or do you, it should be somebody else.
That's what I thought.
It's on the screen.
I move the Quality and Compliance Committee of Private Regional Hospital approve the 2026 Hospice and Home Health Quality Assessments and Process Improvement Plan as presented and forwarded to the full board for final approval.
And with that change to.
With the change noted for assessment for assurance.
Thank you.
So.
Anything else?
I mean, do we have to redo the motion that we made in January to approve to forward the plans for board approval?
Yes, it should go.
So we do need a motion to approve the previous lobby plans that were presented.
We have to present them again, that's what I was told.
Yeah, you're gonna have to bring them again because, not many of the committee members had seen it. Well, actually, Lisa thought, you thought, and you thought.
So we'll have to present them here.
Yes.
Okay. I just wanted to be clear what the process is. And we can't do it this meeting because it wasn't.
You couldn't do it this meeting because you didn't give the public 24 hours notice that you had an action item in the packet. And it's way too big to try to squeeze it into the board packet and just present it directly to the board.
So I'm gonna move on to the committee comments. My next question is this something that we can do at the May meeting or we should have our next meeting in April? May? Okay, next question, how much time do you need for this meeting?
We could do it in an hour and, what I would love the committee to choose is if we could set a cadence for the meeting. Since we have all the committee members here, that would be great. So Anita could put it on the calendar for the rest of the year. We can send the invites out to everyone for the rest of the year. That would be very helpful. So if we did a bi-monthly if it's Thursday, that normally works at this time, that would be very helpful.
It has observations as well.
So if 3:30, the third Thursday works,
For me, because I gave that day up, you know. So,
it's fine for me too. Okay. I defer to our doctors because your schedules are the tightest. May, July, September. January, because that works good for our quarterly, because we try to do it after our quarters end, because that's when most of our data comes out. Because it gives me then a month to compile data. Then I have a month that I can actually meet with you, compile data. And then we can have our meeting afterwards. That's okay, Lisa. Yeah, that is perfect. Thank you, sorry. So then we would meet in April, be prepared for a May meeting. End of April, beginning May.
The two.
Yes. Oh, yeah, perfect. Yeah. Yeah, that's fine. I'll be out of town mid-April, end of April, I got mid-April. Yeah, mid-April. So yeah, end of April is
So beginning of May.
it. Okay, we can adjourn at
Or,
meeting.
not as short as finance meetings, but okay.
Or 14. 14?
Yeah, May 21, is that?
Yes. I'll have Anita book and send out the invite for all of them.